Yes.
For technological reasons, I can't actually see anyone right now. So if there are questions during,
it looks
thank
great.
you, I appreciate it. So if there are any questions that come up during the talk, you're just going to have to interrupt me to let me know. I'm very grateful to have the opportunity to talk today. I have to preface the talk by saying that in true pandemic fashion, I'm doing this from home, and I have my dog with me. My dog is a pug, and so if you hear kind of snoring or someone who sounds like they're in need of an advanced airway in the background, it's just my dog and it's not me. These are my disclosures today. So the title of my talk is New Tricks for an Old Man's Friend, which is a quote that's loosely attributed to William Osler, who's pictured here. As it turns out, Osler never actually said this. The quote's actually derived from one that's shown here. But Osler did have a number of other quotes about pneumonia, which are actually quite insightful. And I'm going to show you a couple right now. The first of which is the most widespread and fatal of all acute infectious diseases, pneumonia, is now, as Osler called it, the captain of the men of death. A few years later, in one of his other lectures, Osler said the wards and the post-mortem room show a very striking contrast in their pneumonia statistics. And I think, what Osler was getting at back in the early 1900s is fundamentally that one, pneumonia is a highly morbid illness, and two, we're not very good at diagnosing it. And what I aim to convince you of today is that more than a century later, despite the multitude of advancements in modern medicine, that in the 2000s, pneumonia is still highly morbid, and we're still not very good at diagnosing it. And the central conceptual thesis of this talk, essentially, is that I think that the way that we think about and use respiratory cultures in this particular illness may represent an untapped tool in our approach to pneumonia in terms of improving its diagnosis and improving outcomes. And so first, a little bit of background about pneumonia. I'm going to be talking about ventilator-associated pneumonia, which I'm going to on and off refer to as VAP. VAP is defined as any pneumonia that occurs after at least 48 hours of invasive mechanical ventilation. And it's highly prevalent. VAP affects approximately 10% of patients who require invasive mechanical ventilation, and it's quite morbid. The all-cause mortality associated with ventilator-associated pneumonia is pegged between 20 and 50%. But the estimated attributable mortality from VAP is probably on the lower end of 2 to 13%, given advancements in modern ventilatory support and antibiotic therapy. VAP has a lot of downstream consequences. It's unequivocally associated with prolongations in ventilator dependence. And it also costs the healthcare system quite a lot of money, anywhere between $28,000 to $40,000 in excess cost per patient are attributed to VAP. And while it's not really billed as kind of a frontline consequence of VAP, a real serious issue that is attendant with VAP is the fact that it recurs not infrequently. If you look at meta-analyses on the topic, the recurrence rate for ventilator-associated pneumonia is anywhere between 10 and 40%, depending on the case definitions that you use and the duration of follow-up. And recurrent VAP in and of itself is a really major problem. So recurrent VAP on top of index ventilator-associated pneumonia is itself associated with increases in mechanical ventilation, prolongations in ICU length of stay, and even independently associated with mortality itself when it's caused by specific bugs. We know that recurrent VAP is also disproportionately caused by multi-drug resistant organisms, many of which have been selected for by the antecedent antimicrobial therapy that patients received for their index pneumonia. And importantly, the issue of VAP recurrence is kind of a focal point in a therapeutic controversy about VAP management. So this is probably the most consequential study on ventilator-associated pneumonia in the past few decades. It's from 2003, and it was a comparison, a randomized controlled trial of 8 versus 15 days of antibiotics for VAP in adults. And what the authors of this study did is they took about 400 patients with VAP and they just randomized them independent of pathogen to 8 days versus 15 days of antibiotics. And what they showed is that there really were no meaningful differences between these groups in terms of their rates of mortality, rates of ventilator dependence, or ICU length of stay. What they did, however, show, and what subsequently has generated some controversy, is that if you look at pathogen-specific subgroups and you just isolate patients with non-fermenting gram-negative bacilli such as Pseudomonas, Acinetobacter, Stenotrophomonas, a group of bugs which are notorious for a propensity to really stick around in otherwise sterile body sites through biofilm formation and a propensity to evolve resistance to antimicrobial therapy while on treatment, they found that folks treated with a shorter course of antibiotic therapy had a higher rate of VAP recurrence than those who were treated with a longer course of therapy. So what are known risk factors for VAP recurrence? I've tried to kind of display them here in terms of what's known. The general idea is like if you're really sick with ventilator-associated pneumonia, in terms of your hemodynamic status or your respiratory status, that you're at really high risk for recurrence. The problem with all of the definite and possible risk factors for VAP recurrence, however, is that none of them are really compelling or even clinically useful in terms of identifying patients with a high degree of certainty who are at high risk for recurrence so that we can target them for interventions to lower their risk of recurrence. And what really we think is needed in this area is either a very reliable clinical predictor, which doesn't yet exist, or something like a biomarker, which can identify patients that we know are going to be at high risk for recurrence. And what we hypothesized was that microbiologic treatment outcomes could potentially be such a biomarker. So we know that for patients with pneumonia, unlike infections that involve normally sterile sites of the body like the bloodstream, a lot of patients with pneumonia not infrequently fail to sterilize their respiratory cultures, even if they've had a really good clinical response to antibiotics, and even when they've received guideline concordant antibiotic therapy. And what's unknown in this situation is whether this actually represents incomplete eradication of infection, which then predisposes to ventilator-associated pneumonia recurrence, or if this just kind of represents a low bioburden residual respiratory colonization that's really not clinically consequential. And the real problem with this is we don't really know what this means. We have a lot of data on microbiologic outcomes from pneumonia from FDA registry trials for novel antimicrobials. The problem is, while trials like this track microbiologic outcomes in pneumonia, they don't do so in a standardized fashion. So there are no standardized tests of cure in patients at the end of treatment. What generally happens is patients are considered microbiologic failures in these trials if they present treating clinicians with a cause for concern for a recurrence. And because of this, the true incidence of microbiologic treatment failure in ventilator-associated pneumonia, and consequently whatever kind of clinical outcomes may or may not be associated with it, is really unclear. And so what we elected to do was try and study this. We worked pretty closely with our data office for clinical and translational research here at the University of Michigan, and basically built a database of hospitalized patients who had an index episode of nosocomial pneumonia, who achieved what we call the clinical cure, and then happened to have follow-up respiratory cultures obtained during that time period where they were clinically cured. And we partitioned patients basically into those who achieved microbiologic cure, meaning they no longer grew the inciting pathogen from their index pneumonia in their follow-up respiratory cultures, and those who had microbiologic failure, who had persistent growth of the same species or pathogen that caused their index pneumonia. And what we were really interested in looking at was the downstream clinical outcomes and any potential associations they had with microbiologic cure or microbiologic failure in the setting of clinically cured pneumonia. And this is a basic schema for how the study was set up. So we first kind of captured patients who had an index pneumonia. And we defined an index pneumonia in the following way. We said anyone who has a respiratory culture with a bacterial pathogen had an index pneumonia as long as they had chest imaging with verbiage in a radiologist interpretation that was concordant with a pneumonia diagnosis, and that they received one new pneumonia-specific antibiotic for at least 5 continuous days after their positive respiratory bacterial culture. And we took all those patients, and then we kept only those who achieved what we called clinical cure, which was essentially discontinuation of all antibiotics, period, for at least 48 hours, as well as survival and no discharge to hospice or transition to comfort care for at least 48 hours. So we didn't use any clinical variables or say that patients all had to defervesce or achieve normalization of a white blood cell count. We just said if the treatment team felt that it was safe to stop antibiotics and all antibiotics were stopped for 48 hours, that was good enough to call a clinical cure. And then what we did is we took patients who had respiratory cultures incidentally obtained during this time period of a clinical cure, anywhere between 3 days before antibiotics were stopped to 7 days after antibiotics were stopped. And we stratified patients into those who had microbiologic cure and microbiologic failure. So importantly, if you had an index pneumonia that was caused by Staph aureus, and you had a follow-up respiratory culture that grew Pseudomonas, for example, we would consider that a microbiologic cure. And so even if you grew another pathogen in the follow-up respiratory culture, as long as you no longer were growing the index pathogen, that was considered a microbiologic cure. And then we looked at downstream clinical outcomes. Our primary outcomes were a composite outcome of death or recurrent pneumonia at 30 and 90 days following the initial treatment for pneumonia. And then importantly, we looked at secondary outcomes by pathogen-specific subgroups. Because this was an automated query to kind of build a database, and because we know that respiratory colonization can be such a challenging feature that confounds pneumonia diagnosis, we actually individually chart and image reviewed every single case in a blinded fashion here to make sure that we were getting really valid diagnoses of pneumonia. So we used IDSA ATS criteria of a new lung infiltrate plus clinical evidence that the infiltrate is of infectious origin to confirm that all the cases that we included in our cohort were really, really legitimate pneumonia. And when we were looking at cases of potential recurrent pneumonia, we captured them the same way, and we similarly subjected all of them to blinded chart and imaging review to confirm that any follow-up case of recurrent pneumonia was really legitimately clinically relevant clinical pneumonia and not just someone who had microbiologic treatment failure and was called a recurrent pneumonia by a treating team. And this is what we found. We, over about 5 years, were able to identify 655 cases of potential index pneumonias who met all these criteria of achieving clinical cure and then having follow-up respiratory cultures obtained in that time period. And after we chart and image reviewed all of these, we were able to build a cohort of about 440 patients with confirmed legitimate nosocomial pneumonia. The reasons for case exclusion after chart review are listed here. Probably the most common was we just didn't feel like the imaging was very compatible with pneumonia. We felt that there was a non-infectious respiratory decompensation that was more likely the cause of the clinical syndrome. Things like flash pulmonary edema, mucus plugging, aspiration pneumonitis rather than a frank aspiration pneumonia, or folks who had clearly an infection, but one that was really localized outside of the pulmonary respiratory tract. And of these 441 cases, what we found was that 237 patients, or roughly 54%, achieved microbiologic cure, And the remaining 204 patients, or about 46% of this cohort, had microbiologic failure. Importantly, within the microbiologic cure arm, about a third of patients still were growing a bug in their follow-up respiratory cultures. It just wasn't the same bug as the index pathogen, which kicked everything off. This is a slightly busy slide, but it's supposed to show a couple of things. So number one, if you look at the blue circles, it gives you a sense of how sick the patients in this cohort were. The majority of patients were in the ICU at the time of diagnosis. They had significant hypoxemia. Anywhere between a quarter to roughly a third of patients required vasopressor support at the time of diagnosis. And it's not noted here, but about 70% of the cohort was ventilated at the time of index pneumonia diagnosis. And what you can also see here is that patients really did clinically improve, right? There were markedly fewer cases of abnormal temperatures at the time that antibiotics were discontinued. White blood cell counts went down in both treatment arms. Most patients got off pressors. Their ventilator status improved. So while this is still a pretty sick and messy cohort at the time of quote unquote clinical cure, there really was meaningful clinical improvement in almost all these patients to warrant antibiotic discontinuation. And these are the top line results of the study. The primary outcomes are shown here. So among patients who achieved microbiologic cure after treatment for their index pneumonia, the rate of 30-day death or recurrent pneumonia was about 33%. And that's in contrast to those with microbiologic failure, who had a 30-day rate of death or recurrent pneumonia of almost 43%. And this was a statistically significant finding. A similar trend was found with the 90-day recurrent pneumonia or death outcome. So folks who had microbiologic cure had rates of 90-day death or recurrent pneumonia of about 38%. And over half of patients with microbiologic failure had either died or developed recurrent pneumonia by 90 days in the microbiologic failure arm. These outcomes were unchanged in analyses that I'm not going to show you, which were stratified by ventilator dependence at the time of pneumonia, index pneumonia diagnosis, and in other stratified analyses that were stratified by the timing of follow-up respiratory cultures in terms of whether they were obtained before or after antibiotic discontinuation. This is the same data, but presented as a Kaplan-Meier survival curve. So the y-axis here shows the probability of survival without recurrent pneumonia as a function of someone's microbiologic outcome to their initial treatment. And you can see the blue line, which represents microbiologic cure, really starts to diverge from the red line representing microbiologic failure about 1 week after antibiotics were discontinued. We also ended up censoring all patients who died in this study to just look exclusively at recurrent pneumonia as an outcome by itself. So death was much more common among patients with microbiologic failure. But even when we censored those patients from our analyses, recurrent pneumonia was still markedly and significantly more common among patients who had microbiologic failure than those who had microbiologic cure. And importantly, if you actually looked at the pathogen which caused the recurrent pneumonia, in folks who had microbiologic failure, recurrent pneumonia in 93% of the cases was caused by the exact same pathogen that precipitated the index pneumonia, Whereas if you look at the microbiologic cure arm, only about a fifth of the episodes of recurrent pneumonia among those patients were caused by the same bug that kicked off the index pneumonia. We did a multivariable logistic regression analysis of this, the details of which I'm happy to provide to any of those interested in the statistical approach here. But the short story is that we incorporated a lot of things that you would kind of consider clinically meaningful in terms of burden of comorbidities and Apache scores and immunocompromised status and tracheostomy dependence. And we found that the outcomes that we observed in our initial analysis were really, really unchanged. And there was still a significant trend. Sorry, I didn't know if that's, I can't actually see the screen right now. So if you have a question, please just chime in. The pathogen-specific subgroup analysis is presented here. And what you can see here, and what I think is very interesting about this data, is that the strong effect, or the strong association between microbiologic failure and recurrent pneumonia or death was really driven by either Staph aureus or non-fermenting gram-negatives. And the effect was not seen for pneumonia caused by Enterobacteriaceae, or Enterobacteriales, as I think it's now called, which we thought was a fairly provocative finding. This is a study that had obviously a lot of limitations. So first, these are really, really sick patients, and the generalizability is a little tough to kind of apply to patients who are less critically ill. There was a lot of variability, importantly, in sampling modalities. So we didn't preference bronchoalveolar lavage versus endotracheal aspirate cultures. We didn't distinguish between sub-quantitative culture growth and super-quantitative culture growth, or preference quantitative versus qualitative respiratory cultures. And I think most importantly, this is really a study not of, again, all comers who were treated for pneumonia and then had their respiratory tract sampled afterwards to see what their microbiologic outcomes were. It was, again, still a study where the treatment team had to go beyond what we would consider the standard of care and sample the respiratory tract after treatment for some reason. Importantly, a lot of patients in this study had follow-up respiratory cultures obtained, not because the teams thought, gosh, they have pneumonia again, but just because there's a lot of strange reasons why people obtain respiratory cultures. There were a lot of patients on ECMO in this study who get surveillance bronchoscopies, and a good number of patients during liberation from mechanical ventilation happened to have respiratory cultures pulled while they had the tube in for reasons that are not entirely clear. But it's still tough to generalize this patient population to all comers. And I think importantly, the study doesn't really denote a causal link between failure to eradicate a pathogen and downstream recurrent pneumonia, nor does it really suggest that we should be aiming to achieve, microbiologic clearance as an outcome for patients with VAP and leave them on extended antibiotics until they no longer grow germs in the respiratory tract. People who fail to clear their cultures, that in and of itself might just be a surrogate marker for non-microbiologic conditions, which are associated with an increased risk for death or recurrent pneumonia, like baseline abnormal lung architecture, or really impaired pulmonary hygiene, aspiration frequency, a poor host immune response, or ongoing dependence on mechanical ventilation. But it is, I think, an interesting finding, and it's also possible, if not biologically plausible, that in selected patients with the right kind of germ, that microbiologic failure in the setting of clinical symptom resolution might actually represent incomplete eradication of infection. And we therefore think that a prospective study of something like this is really warranted to assess the real association between microbiologic outcomes in pneumonia and then their downstream clinical effects. And so this is what we're trying to do. This is called the HOMER study, and it's basically geared up to be a prospective evaluation of ventilator-associated pneumonia patients who achieve clinical cure with guideline concordant therapy and who then would consent to have their respiratory tract sampled after treatment. And what we plan on doing is following these patients prospectively to see if there really is any meaningful difference between those who fail to eradicate their respiratory cultures after treatment and those who do going forward. So with that, I'm going to gear shift a little bit and move away from pneumonia treatment and more towards pneumonia diagnosis. And if you recall at the beginning of this talk, I gave you two quotes from William Osler, which hammered home the fact that, pneumonia is highly morbid, even now. but also that we're really, really bad at diagnosing it. And this is particularly true, and I think uniquely true, of ventilator-associated pneumonia. So going back to a little bit of background information on ventilator-associated pneumonia, we know that treatment of respiratory infections in general is responsible for the vast majority of ICU antibiotic use. We also know that it's really challenging to diagnose ventilator-associated pneumonia in critically ill patients because the clinical signs and symptoms like hypoxia, fever, leukocytosis, or an increasing secretion burden are incredibly nonspecific. And there's a multitude of non-infectious causes of these things, or extrapulmonary infectious causes of these things, that may incent pneumonia mistreatment and misdiagnosis. We also know that even if you take people who fulfill VAP clinical criteria that's set out by the American Thoracic Society or the IDSA, that up to 50% of them don't actually have histopathologic evidence of pneumonia in autopsy studies. And what this all results in is that there's a real problem with overdiagnosing ventilator-associated pneumonia within the ICU. And overdiagnosis of pneumonia is more than okay in many situations. This is a really highly morbid infection where early and aggressive antimicrobial therapy clearly makes a difference. And it happens in really clinically tenuous and vulnerable patients. And so the threshold for treating something like this by necessity has to be lower than it would for an ambulatory or even a floor patient. But even with all those caveats, there's really mounting evidence that when it comes to pneumonia diagnosis, we're really overdoing it. And we know this for the following reasons. So number one is the fact that if you look at the past few decades and you just trend out ICD codes, discharge diagnoses for pneumonia have increased about 20% in the last few decades. And that's not a trend that's seen in any of the other 10 most common causes for inpatient admission. We also know from a study of more than 12,000 patients who were hospitalized with pneumonia that about 1/5 of those lacked any cardinal signs or symptoms of pneumonia: fever, white count, purulent sputum, hypoxemia, anything. And then when it comes to ventilator-associated pneumonia in particular, we know that from a number of multidisciplinary case reviews where you combine medical and surgical intensivists along with ID physicians, that a majority of cases that are labeled as VAP and treated as VAP by frontline ICU treatment teams don't actually meet diagnostic muster for ventilator-associated pneumonia. And I think this is a really clever study that kind of crystallizes that point, because it appears very likely and increasingly likely that people are equating ventilator-associated pneumonia with growth of germs from sputum in mechanically ventilated patients. So this was a really clever study by Mike Klompus and his group of about almost 1,300 adult patients. And they took these patients who were on invasive mechanical ventilation but had very minimal ventilator requirements, who happened to grow a germ from a respiratory culture. And they partitioned folks into those who were treated with less than 3 days of antibiotics but still received antibiotics, and those who were treated for more than 3 days of antibiotics. And what they found basically is that there were really no meaningful clinical differences between these two groups. Folks who were treated with these quote unquote ultra short courses of antibiotics had similar in-hospital mortality, time to hospital discharge alive, time to extubation alive. And, in a study like this, there's obvious issues with confounding by indication, but I think, the takeaway here is that either some patients really have VAP that is incredibly mild and can be treated safely with a very short course of antibiotic treatment, or that some patients who are diagnosed with VAP based on positive respiratory cultures really never required antibiotics in the first place. And our experience at our hospital really reaffirms this. So we used a similar strategy to the one that I initially showed you for data collection for this study, and examined a cohort of 705 patients who had positive respiratory cultures for a pathogenic bacteria. and were treated for bacterial pneumonia here at our hospital at Michigan Medicine. And after doing a chart review of all these patients, we found that 1/3 of them clearly did not meet real legitimate diagnostic criteria for pneumonia. And recognizing that for something like pneumonia, which again is highly morbid and requires aggressive empiric and targeted therapy, recognizing that a really high burden of proof has to be met to defer antimicrobial use, we sought to quantify unnecessary antibiotic use in this subset of patients who did not have pmeumonia in as conservative a manner as possible. So we basically considered antibiotic administration appropriate if patients had pathogenic organisms isolated from cultures outside of the respiratory tract.
Hey, Owen, hold on.
Yeah.
If everyone can mute their lines, I think there's some background noise. Thanks.
So we said that antibiotics would be appropriate in folks who didn't have pneumonia if they grew germs outside of the respiratory tract, if treatment teams clearly documented that they thought they had ventilator-associated tracheobronchitis, if folks had an acute exacerbation of COPD or cystic fibrosis, or if the patient was a transplant patient or heavily immunocompromised and just happened to grow a germ from their respiratory tract, even in the absence of clinical criteria for pneumonia. And even with all those allowances, we still determined that antibiotics were administered completely inappropriately for a median duration of 12 days in these patients in 151 cases out of 705 cases, which is almost a quarter of the entire cohort. And to me, what this really kind of hammers home is the fact that it's just really, really, really difficult for people to not treat a positive respiratory culture in a sick patient on invasive mechanical ventilation. And there's a lot of reasons for this. A lot's been made about cognitive biases and how they interplay with antimicrobial stewardship. There are things such as commission bias, which providers have a tendency towards action versus inaction and feeling like they want to do something with antibiotics rather than withhold them. There's confirmation bias, which is a tendency to seek out evidence confirming an initial hypothesis. So if a patient has a post-operative fever and is treated for a germ that grows in their sputum and then they defervesce, that defervescence is seen as proof that the antibiotics are working and validation that the pneumonia diagnosis was appropriate in the first place. There's diagnostic momentum, and this is a huge issue nowadays with duty hour restrictions at academic medical centers, because you often have cultures that are obtained by like a house officer overnight, and then that's passed along to a day team, and then that's communicated to an attending. And over time, a diagnosis tends to be solidified when it's just kind of passed successively between providers and teams. And then obviously, we're all used to calling things pneumonia that probably really aren't pneumonia. And so we often anchor ourselves on this diagnosis when it's not really there. And as a result of all of this, a lot of the traditional stewardship approaches to mitigating antibiotic overuse for pneumonia have had really limited success in ICUs. Most stewardship interventions that target ventilator-associated pneumonia are really focused on how do we de-escalate or discontinue antibiotics in patients with established diagnoses, rather than questioning the diagnoses in and of themselves, right? And I think, once the diagnosis, in other words, is out of the bag, it's really, really, really hard to put back in. And what we think instead is needed is an approach that actually focuses on diagnostic stewardship. So diagnostic stewardship is basically a set of interventions that target the diagnostic testing pathway to minimize overdiagnosis in the first place before antibiotics are prescribed or continued. And this is really kind of the whole concept of diagnostic stewardship. When you look at the diagnostic testing pathway, there are really three phases that people tend to focus on. One is the decision of when and how to order a test. The second is the collection or processing phase of the diagnostic testing pathway, where the actual test is collected, how it's collected, and how it's processed and sent to a lab. And then the third phase of the diagnostic testing pathway is how that test result is reported and or communicated to other providers. And interventions at the diagnostic testing pathway level for VAP have really not ever been trialed. What they have been trialed in is asymptomatic bacteriuria. So we know with asymptomatic bacteriuria that there are a lot of parallels with ventilator-associated pneumonia. We know that it's common. It's present in about 20% of community-dwelling individuals and obviously much higher in healthcare settings. We know that finding bacteria in the urine is not synonymous with an infection, but actually requires clinical correlation. And we know that there are diagnostic stewardship approaches that are very successful in lowering overdiagnosis and antibiotic overuse in treating presumed infections within the genitourinary tract. And so if you actually look at this schema for asymptomatic bacteriuria, we know that if you implement strict clinical criteria to guide when to actually order a urine culture, that can reduce UTI overdiagnosis. We know that if you get a high quality sample of urine rather than a poor quality sample, that is also very helpful at lowering overtreatment. So getting a clean catch void or like a fresh bladder cath rather than pulling cultures off of an existing Foley bag is really important. And we also know that interventions at the level of the micro lab, such as using pyuria as a way to greenlight urine culture performance, or the way in which we report respiratory urine culture results in terms of which organisms are significant and which are not, have really meaningful impacts on downstream antibiotic use. And the question in our mind is whether a similar kind of multi-pronged diagnostic stewardship approach would benefit respiratory culturing practices within the ICU. And for this reason, we think it's kind of instructive to frame the VAP overdiagnosis issue in the same terms as UTI overdiagnosis. So instead of asymptomatic bacteriuria, we have asymptomatic bacteriosputia. So what do we know about quote unquote asymptomatic bacteriosputia? We know it's common. So a quarter of hospitalized patients, if you swab their oropharyngeal tract, are going to grow pathogenic organisms. We know that this number rises to about 50% in critically ill patients, and it rises to a really alarming rates in folks who have indwelling prosthetic endotracheal material. We know that finding germs in the respiratory tract, particularly the proximal respiratory tract, is a pretty nonspecific finding, and that it's not synonymous with pneumonia and really requires clinical correlation to cement a diagnosis. But unlike asymptomatic bacteriuria, we don't have really robust diagnostic stewardship approaches for something like this. And so what would a diagnostic stewardship intervention for ventilator-associated pneumonia look like? So using this exact same framework that I just kind of walked through for asymptomatic bacteriuria, I'd like to walk you through one for ventilator-associated pneumonia. So the first question is, can we lower the number of indiscriminate respiratory cultures that are ordered? We think that we can. So in our institution, there are lots of reasons that patients get respiratory cultures ordered who really do not have pneumonia. I've listed some of them here. A fairly common one is patients have thickened secretions or increased secretions, even though those secretions are not actually purulent. So we get a lot of patients as a referral center from outside institutions. We put them on a humidified ventilator circuit that starts to mobilize their secretions. They come up, they're getting better, but that's seen as an indication of pneumonia, for example. We know that after the initial phase of critical illness, a lot of patients are wet. They need to be dried out with diuretics. That often thickens up secretions and causes an increasing and thickened secretion burden. That's often used as a reason to greenlight respiratory culturing ordering. We know that in patients who mucus plug or have an aspiration event, and then even in patients who fail spontaneous breathing trials for reasons like anxiety or just the fact that they're clearly not ready to get off the vent for a non-infectious reason, tend to have respiratory cultures not infrequently obtained. This next one, clear VAP mimics, is a slightly more challenging, but particularly in our cardiac ICUs, we see a lot of patients with decompensated heart failure who, just because they have some gunk on their chest x-ray and maybe a little bit of a white blood cell count, in the setting of heart failure tend to get their sputum cultured. But far and away, the most common reason, at least at our institution, that we see patients getting respiratory cultures obtained who really don't have evidence of pneumonia is as part of what we call a pan culture workup, right? For a new fever or a new white blood cell count in a critically ill patient. And I think most people who practice ID have seen this before, where in the ICU, if a patient develops a fever or a white blood cell count, it really feels like a game of whack-a-mole. So the treatment team gets, cultures from almost every bodily orifice imaginable. And if you find a bug, you just treat it, right? And that's kind of where the thought process stops. But the problem with this is it's really kind of silly, right? So if you assume a 10% prevalence of ventilator-associated pneumonia in a mechanically ventilated patient, and then you take a patient who's mechanically ventilated and you say, well, you're febrile, but there's no new radiographic infiltrates on chest imaging, there's no purulent sputum, and there's no meaningful change or decompensation in the patient's ventilator settings, before ordering a respiratory culture, the pre-test probability of ventilator-associated pneumonia is 2.9%. And even if the patient grows Staph aureus on a endotracheal aspirate, the post-test probability after growing that goes up to 3.6%. So a positive respiratory culture in this context barely moves the needle at all. It can tell you how to treat ventilator-associated pneumonia, but not whether to treat ventilator-associated pneumonia. And we actually studied this. We took patients who were on invasive mechanical ventilation for more than 48 hours and had a new fever or leukocytosis, but had stone cold stable ventilator requirements in terms of their PEEP or FiO2 over time, who did not have any report of increasing secretion burden, who did not have any radiographic evidence of pneumonia, and who were not sick on vasopressors and didn't have cystic fibrosis. And what we found is that patients who, as part of the response to their fever or white blood cell count, those who had respiratory cultures obtained for this reason, had significantly more broad spectrum and total antibiotic use associated with their care within just 1 week of that respiratory culture order. This is data that we've now packaged up in a propensity score stratified cohort, and we actually just submitted it to CID yesterday. So I'm not going to show you the rest of it here, but what we also did in the study is we actually chart reviewed all the cases and confirmed that really none of the patients had pneumonia. But again, if you have a positive respiratory culture in a critically ill patient, it really creates an incentive to treat with antibiotics. So yeah, it's likely that we can use similar kind of decisional support systems to more rationally and discriminately order respiratory cultures in mechanically ventilated patients. What about the second phase of the diagnostic testing pathway for VAP, which is the test collection phase? So we know, at least at our institution, that most respiratory cultures in the ICU are endotracheal aspirates. About 60% of cultures in our ICUs are obtained via endotracheal aspiration, and about 40% are obtained by bronchoalveolar lavage. At our institution, BAL can be done non-bronchoscopically with a called a blind or mini BAL that's performed by a respiratory therapist. It has the same cost in terms of labor and supplies as an endotracheal aspirate. And it's actually what's recommended for VAP diagnosis according to the European HAP-VAP guidelines, whereas the American guidelines take a kind of middle ground stance and say, we don't really care of one versus the other. But there's a lot of reasons to think that performance of BAL actually has a stewardship advantage. And so why is that? So this is a study from many, many years ago. It's an animal study of a baboon ARDS model, where they basically took cultures of baboons' respiratory tracts sequentially along the respiratory tract. And then they compared the culture yield at each of those locations in the proximal and distal respiratory tract to homogenize lung tissue that was obtained after autopsy for the baboons. And what you can find here is that the yield of BAL and the yield of tracheal aspirate are actually very, very similar in terms of how many organisms they tended to recover in patients, or excuse me, in their baboon subjects. But what you actually see here is that the results of the cultures that were obtained bronchoscopically generally mirror what was grown from homogenized lung tissue. Whereas the majority of germs that were grown when sampled from the endotracheal aspirate approach did not actually approximate what was grown in the lung tissue itself. We also know from a couple of RCTs now that while invasive lung sampling with bronchoalveolar lavage is not really associated with a mortality benefit, a reduction in the duration of mechanical ventilation, or other kind of clinical benefits, it is consistently associated with lower antibiotic use across the board, and consistently associated specifically with more antibiotic-free days in randomized controlled trials when compared to proximal lung sampling. So, it's my belief that a more BAL forward approach to obtaining respiratory cultures in critically ill patients actually has a stewardship benefit, and it's not being appropriately leveraged right now by the majority of hospitals within their ICUs for a stewardship purpose. And then we think the last thing that we can actually glean from urinary diagnostic stewardship is we don't routinely utilize other data from respiratory specimens, like we do a urinalysis, for example, to help determine the significance of what to make of organisms that we grow out of respiratory cultures. So, for example, we know that pyuria has an exquisite negative predictive value. And many, many hospitals and healthcare systems have used the presence of pyuria as a prerequisite for urine culture growth. You can't order a urine culture without actually having a urinalysis that confirms pyuria. And what we know from some of our collaborators at Northwestern is that if you can do something actually very similar with a BAL specimen. So if you take a BAL specimen and you send it for a routine cell count and diff, if you have less than 50% of PMNs in that BAL specimen, that has a negative predictive value for VAP of over 95%. And this is data from some of our collaborators that was obtained in a population where BAL was performed when there was a clinical suspicion for pneumonia to begin with. So it's a very pneumonia-enriched population. But importantly, this is a finding that's actually been confirmed decades ago when you use autopsy studies and histopathologic evidence of pneumonia as a reference gold standard for ventilator-associated pneumonia diagnosis. And so if you put all this together, it's our belief that we can really implement like a diagnostic stewardship bundle in our ICUs to lower VAP overdiagnosis and overtreatment. We've called this the DEVIL study, the diagnostic evaluation of ventilator-associated pneumonia in low-risk patients. I've laid out the hypothesis here. The idea is what I've just laid out to you, that indiscriminate respiratory culture collection and interpretation in mechanically ventilated patients incents unnecessary antibiotic use. And what we're currently in the process of doing is rolling out a staged pilot feasibility trial, which we then will hope will inform and support a stepped wedge cluster randomized trial at the level of individual ICUs of a VAP diagnostic stewardship bundle. And this is what the diagnostic stewardship bundle looks like. So in the ICUs that we're piloting this intervention in order now to order a respiratory culture, you are going to have to select a very clear indication for why you are ordering it. And just, a fever or a non-specific white count will not qualify. We are going to be moving collection of respiratory cultures to basically a BAL for all approach. These are going to be done blindly by our respiratory therapists, or if treatment teams want, they can actually do it bronchoscopically themselves. We are obviously going to have, contraindications to this, like folks who are coagulopathic or severely hypoxemic. But the hope is that we then pivot away from proximal lung specimens, which we think are fairly nonspecific as a whole. And then last but not least, we're going to be implementing and using BAL neutrophilia, or the degree of BAL neutrophilia, as a prerequisite to release respiratory culture results. So unlike urinary stewardship, we're still going to keep the same processes in our micro lab for working up respiratory specimens. But if a patient who has a BAL has a PMN percentage of less than 50%, the culture results will actually be censored and not reported to the treatment team. And teams will then have to, if they want to get the cultures manually released, they'll actually have to call the micro lab to manually release the cultures themselves. And the hope is that this significantly, or at least in a meaningful way, lowers pneumonia overdiagnosis and overtreatment in a meaningful way. And so with that, I think I'm going to stop because I've spent the last 50 minutes without actually looking at anyone's face. And I'm happy to open things up for questions.
All right, anyone who has a question, Owen, that was a great job. And Owen, the one thing I would do is I'll try to post in the chat some of the references. I don't know that you put.
I have them at the end, yeah.
Okay, yeah. And if you can maybe share the slides as a PDF, if you don't mind, we can circulate them to anyone who's interested. And does anyone have any questions for Owen?
Who helps you make your acronyms?
My son. He also helps with the Simpsons icon.
Yeah, this is Mel. I have I particularly enjoyed Bacteria, and for the years and years that that we've seen all these patients and handled all these sputums in the lab. Honestly, I couldn't agree more about the issue of over-ordering. And I would encourage you to, well, let's say you're already doing it, but we'll look forward to the results of the study. Good study.
Thank you. Yeah, no, it's a huge problem in our lab too. And like most good stewardship initiatives, I think one of the benefits of something like this is it really leverages collaboration between clinicians and the microbiology lab itself in actually trying to meaningfully change antibiotic prescribing and diagnostic approaches to infections.
It's Susan. I just wanted to comment, I always look at the gram stain, and I always encourage people to look at the gram stain. And one of the things that I think has been hindering us in our particular institution for some years has been the way the electronic medical record enters things into the chart, because, you can hit a button and insert the lab results, but for some reason that I don't understand, and maybe Mel or Tom can talk about the obstacles, when you put in any of the cultures, it doesn't put in the gram stain, and you have to go in and manually put in the gram stain, and people don't look at it. And that is something that I'm really hoping that with our switch over to Epic may change.
We don't have that specific problem at our institution, but I think the bigger issue is that most people don't even look at the gram stain, right? And the gram stain actually has an exceptional negative predictive value for ventilator-associated pneumonia, right? So if you grow something, but you actually have a negative gram stain, particularly from a BAL, you can, with a high degree of confidence, not treat for pneumonia. And that is actually something else that we're exploring, putting like a verbal nudge into microbiologic reports, where if a patient has a negative gram stain, it says something to the effect of, hey, just so you know, the results of this, you should probably take with a grain of salt. This has a negative predictive value for pneumonia of blank.
I like that very much. I also have been trying to work on this sort of pan culture mentality for many years, and I've been finding it's a real uphill battle to try to get people to get away from that sputum culture, urine culture, blah blah blah. I mean, people who don't pee should not have urine cultures. People who have no tracheal secretions don't send something. And I have a really hard time with that when someone, even, and maybe some of the pulmonary people could comment on, what's the utility then if a person has absolutely no secretions, for having the nurse or the respiratory therapist have to throw saline or something down there in order to get enough of a specimen to culture? And how have you been able to change that mentality?
Well, we haven't yet. The idea behind this intervention is that, an educational initiative is alone not going to do anything. And so what we're really trying to do is just say, like, this is not a reason that you can order a respiratory culture. Now, obviously, people have, epic clicking fatigue, right? And they'll probably find ways around this, but we're actually just trying to restrict culture ordering, where we basically remove fever or leukocytosis from the decision-making equation.
Oh, and I also think, you've mentioned this, but a really critical, this doesn't work without collaboration, multidisciplinary efforts. And you have respiratory therapists, you have you have the intensivists, of course, are the key people. And you have ID, and this is really a joint effort. And this type of work could not be done without cooperation and collaboration at multiple levels. So it's not easy to pull off, which I commend you for getting this far. But really, you need people to want it to happen at multiple different stations.
You do, and what you also find when it comes to secretions in critically ill patients is you really need nursing buy-in too, because the vast majority of clinicians really have not ever seen what sputum looks like in their patients, right? What they do is they talk to the bedside nurse and they just say, like, well, what does it look like, right? And then the nurse says, well, it's kind of thick and like it's been gloopy. I didn't have them yesterday though, so I don't know if this is a change, right? So we're really, really trying to enlist nursing, ICU nurses as well in the effort.
I think we're coming down. We're running past 2. I want to thank Owen. Owen, if you wouldn't mind, if you're comfortable sharing your slides as a PDF, Tanea, maybe we can get some sort of library going of talks. I think that would be great. But Owen, thank you so much. I really appreciate your time and effort, and keep up the good work. Everybody get back to work. Thank you all.